There will be an opportunity for questions, and you can feel free to unmute yourself and pose your question then. At the end of today's session, I'll be reviewing instructions for claiming CME credit, and we will also dedicate 5 minutes at the end of this session to complete your post-webinar survey. All right, that is enough from me. It is my pleasure to welcome Dr. David Turak. Dr. Turak is an experienced OBGYN, educator, clinical researcher, and let's just call a spade, an all-around awesome human. Following residencies in family medicine and obstetrics and gynecology, he worked for the community health centers in Salt Lake City for over 12 years. Currently, he directs the family planning division at the University of Utah, where our multidisciplinary team's current focus is family planning elevated. Dr. Turak is involved in a variety of research projects, expanding contraceptive access and developing new products. He wrote the up-to-date chapter on emergency contraception, has published over 90 research articles, and serves on the editorial board for the journal Contraception. Dr. Turak's research and mentoring efforts at the University of Utah are supported by an NIH Mid-Career Research and Mentoring Award. Dr. Turak, take it away.
Thank you, Caitlin. Thanks everyone for joining. I have a question, Caitlin. Should I be screen sharing?
Yes, if you wouldn't mind just grabbing
right.
control of this screen now.
Knucklehead. Good move on my part. Okay. All right.
Great.
Okay, we're rolling. Sorry about that. So I am very excited to share with you all some thoughts on how I think we can provide better contraceptive care to people. And a lot of it is just based on the idea of when people show up, they should get the method that they want, and us as providers being open to the idea that we're not going to always get it right, and people don't always align perfectly with their desires on choice one. And part of our job and our responsibility is to be there for people when they come on back and get a new method. This talk could alternatively be titled Freedom from the Fear of Luteal Phase Pregnancy. And I'll explain that a little bit more as we go. But in my 25 plus years of clinical practice, I have definitely noticed many more times where we have erred on the side of, as providers, not providing people with the method that they want on the day that they present, and seeing the undesired consequences of that, frequently in the form of unplanned pregnancy. So let's look around and see what we can do about why we have practiced this way, and how we can do better, and what the guidelines and what the data and the evidence show us about how to do this. So objectives and outlines. We want to help our clients get the method they want today. And just to review, the quick start of all methods in some way, shape, or form is supported by the CDC's selective practice recommendations. And menstrual cycle information can help with this, and we'll talk about cases where pregnancy tests can also be helpful. So what is Quick Start? It just means that people get the method that they want when they present for care, regardless of where they are in the menstrual cycle. And it's all based on this thinking that is hopefully is becoming antiquated. Maybe it already is. It's definitely going to be antiquated at some point. And the idea was that when people start a new contraceptive method, they start within the first 7 days. When we do that, we know for people who are having a regular menstrual cycle that they're not pregnant at that time. And this is, the easiest time for us to predict that reliably. And if people were going to be exposed to combined hormonal methods, they would interfere less probably and create less irregular bleeding if they started at the very beginning of the menstrual cycle rather than in the middle. And then finally, the idea was to avoid a quote, luteal phase pregnancy. And the idea there was that we really didn't know what would be the effect on a developing embryo or fetus if they were exposed to exogenous progestins, especially very, very early on. So we would reduce that risk by essentially having people start their contraceptive method when we knew that they weren't pregnant in those first 7 days of the cycle. And that was a special concern, I think, for male embryos and fetuses, with essentially the idea of exogenous progestins might somehow alter their secondary sex characteristics. And that's not like unreasonable at the time. And think about this, like when this is a new thing, thinking way back to the onset of use of the oral contraceptive pill and use of exogenous progestins, we didn't know a lot about that. And we didn't really have data to influence thoughts on really any of those issues. It seemed like a good and reasonable thing. And there was so much that required some level of caution, I think, within the medical community with early use of exogenous progestins to control fertility, that people wanted to err on the side of caution. And all of that is well and good. And super important, there wasn't a highly sensitive urine pregnancy test available in every dollar store anywhere you went, or the grocery, or the pharmacy. The tests were nothing like what we have today. So they weren't as reliable, and they weren't nearly as precise. So the chance of missing an early pregnancy was much higher. So now I think it's incumbent upon us to reconsider this whole process. And the CDC has done a good job of doing that and helping us, as has the WHO. So let's think about this a little bit. And as we do, it is also super helpful for us to think about reproductive justice. And this is an absolutely beautiful foundation for us to consider really any issue of reproduction. And it's based on the meeting of a group of Black women in 1994 who came up with this fabulous framework. And it's a really instructive way to help us think about really any issue involving reproduction or trying to prevent that. And it's durable. And it's only getting more and more impactful and more appreciated, which speaks to the quality of the work that these women created. And the picture is of Loretta Ross, who's considered, who was one of those 12 founding women and considered by some to be kind of the founding mother of the movement of reproductive justice, or RJ. And this is just a picture of the cover of one of the books that she's written. And I just think an absolutely awesome resource. If you haven't seen it, it's very much worthwhile. And the foundation of reproductive justice, that people who have the ability to reproduce can have a child, not have a child, and raise their children in safe and healthy environments, is really bedrock foundation for us to think about anything. And of course, and I think a probably more common addition that's going to be coming up is, in addition to those three aspects of the human rights framework that is RJ, is the ability to enjoy your sex life as you desire. And this is where we can make a significant contribution, in combining principles of RJ with evidence really is a great recipe for best care. So a lot of that concern about the luteal phase pregnancy is easier to appreciate with understanding of the fertile window. So this is a diagram that you've likely seen before if you've had any medical training around in the area of reproductive health. And it essentially shows what's happening at the ovary, the anterior pituitary, the ovarian hormones, and the uterine lining simultaneously over the course of in this case, 28-day cycle. And the fertile window is important to appreciate because this is the time when, really, the only time when pregnancy can occur. And it's based on predicting the day of ovulation, which is best predicted as 14 days prior to the onset of the next expected menstrual cycle, the next expected menses. And if you have a regular menstrual cycle, that could work pretty reliably. If you don't, then it's really not helpful at all. But let's just assume somebody has a regular cycle and we can predict that day of ovulation. The ovary releases the egg, and the egg is only available to be fertilized for essentially 24 hours around that time of ovulation. But it turns out, in the only aspect of human being, I think, where the male component can hang out and wait and be patient more than the female component, sperm can essentially go into a quiescent phase in the fallopian tube where they can get to within literally minutes and hang out for 5 days. And when an egg is released at any time during that period, they can undergo what's called capacitation, where they reactivate and then can penetrate the egg and cause fertilization. So essentially, if you had sex anytime from 5 days before to 1 day after ovulation, those are the times when fertilization can occur. Now that's different than pregnancy. Pregnancy requires a fertilized egg. So there's our sperm that got up to the fallopian tube, and it's almost that fast. And then upon release of the egg, if that occurs within a time period of when both are present and active, you can get a fertilized egg. Now it takes a few days and 24 hours to go from that fertilized single fertilized egg to a 2-cell, the beginning of the blastocyst with two cells, and then basically implantation on day 6. And every credible scientific organization on the planet defines pregnancy by implantation. And we now have, as I had mentioned earlier, super reliable ways to detect that with widely available urine pregnancy tests. So the WHO and the CDC, in a desire to really make, to be less restrictive about initiating contraception, came up with this idea of the pregnancy checklist. And excuse me. And the idea here was, in low resource settings, to be able to provide clinicians with some guidance who might not even have the ability to do a urine pregnancy test, to be able to assure them that somebody's not pregnant if these criteria can be met, and you can start them confidently on a contraceptive method. And those 6 criteria are being in the first 7 days of the menstrual cycle, having not had intercourse since your last period started, correctly and consistently currently using a contraceptive method, being less than 7 days from a spontaneous or induced abortion, being within 4 weeks postpartum, or meeting the criteria for lactational amenorrhea, be fully breastfeeding, not having had your period return, and being in the first 6 months after birth. So the pregnancy checklist has been, was designed essentially to be something that opened up the ability to use contraceptives with less restrictions. And the current selective practice recommendations say these don't need to apply for the pill, patch, ring, injectable, or implant user. So basically, you can start any of these methods, even if the pregnancy checklist is not met. And that leaves out IUDs. And specifically, this is from page 7 of the CDC SPR, the Selective Practice Recommendations. And if you don't have this, it's a super convenient and highly useful app that you can get on the App Store. And just by typing in CDC MEC or CDC SPR, either way, it'll come up. It's free, and it basically has these two components: the medical eligibility criteria, which help you safely use contraceptive methods and apply all the different methods to over 200 different medical conditions, and then the selective practice recommendation, which addresses a couple of dozen common clinical situations where you may commonly scratch your head about what you can use when, as far as safety with starting contraceptive methods and continuing them with people you're caring for. So next to the pregnancy checklist, there's essentially a qualifier about IUDs. And in cases where people are uncertain whether somebody is pregnant, they're saying they should be provided another contraceptive method, because now we know that if somebody is using one of the current methods, aside from IUDs, we can just stop it, including the implant, if they get pregnant. And if they want to not continue the pregnancy, they can have an abortion and leave the implant in place and it'll still work. Or if they're going to continue a pregnancy, any of those methods can be stopped very quickly, or without adverse effects, or the implant can also be removed. So, as I had mentioned several times already, this is all about avoiding the luteal phase pregnancies. And let's dive in a little bit about how, trying to figure out, like, how many people will we need to tell you got to wait and come back some other time, which we know is challenging for people and reduces the chance that somebody's going to get the method that they want on the day that they present. So let's dig a little deeper into the data. So Carolyn Westhoff, in her infinite wisdom, really thought these restrictions were not helpful and were limiting people's access to contraception way, I think, before anyone else, and certainly was publishing articles about it before anyone else that I'm aware of. And she and the group, her group at Columbia, started to look at birth control pills. And they were essentially doing what I'm saying, providing people with the method that they want on the day that they show up. But they were trying to gather some data to demonstrate to the rest of the world that this was okay. So if you came to the Washington Heights clinic and the other clinics where they worked and wanted to start pills, at the time they did this, what was considered revolutionary, and they would say, here's your first pack, and please take your first pill now. And the idea was that you're just helping people get in the flow and show them how easy it was and take out some of the mystique of starting it on their own. So they looked at essentially, just retrospectively, people who got the pill that way in any day of the cycle versus people who were told, wait till your next period starts and then you can start the pill, or use a backup method, use condoms or abstinence, and then start the method in those first 7 days, or start on Sunday, because people used to always tell everybody that. And essentially they compared these two groups. So they had, of the 80% of the quick starters, and their primary outcome was looking at who essentially initiated that second pack of pills. And and there was less appreciation at the time that pill continuation is really quite low. About half of people are still using a pill prescription or less at 6 months, and a quarter to a third at a year. But anyway, in their group, 80% of the quick start users began their second pack, and a little bit less than that in those who were told to delay the start. And and that demonstrated an early adjusted odds ratio to show that maybe there was a benefit to to providing quick start as far as ongoing contraceptive use. So the next thing they did was a large randomized controlled trial with over 1,700 people, and they followed them for 6 months. And as they looked at the primary outcome again as getting to that second pack of pills. And then there was a 50% increased chance of that happening. But there was actually no difference in OCP continuation at 3 and 6 months. However, it looked like the 6-month pregnancy rate was less for quick start users. So again, it's not overwhelming evidence that one of these, it seems the quick starting oral contraceptive pills at this time and in these studies showed improvement, but there's a bigger issue I think that also needs to be addressed beyond just the data, and that is, what did people think about the experience? And people have a human right to and a right in their medical care to direct their care and be an active participant in it. And that drives, I think, the need to provide care now. So then they went on to look at it, this with Depo-Provera, and they did a few studies before they did a randomized controlled trial of Depo Now, the day that you walk in, versus the bridge method, which meant that we're going to have you use a backup method, and then when you have your next menstrual cycle, come on back and we'll give you the injection. So they randomized people to those two things, and more than twice as many, it was more than 2-to-1 randomization for the bridge method. And in the bridge method group, 55% actually returned and got their first Depo shot. So clearly, there was, and everyone who was in the Depo Now group got it. So they went and looked at the third injection. So that's showing up for that third injection. So 6 months out, 30% in the Depo Now and 21% in the bridge method group, trending toward significance. And the big difference, though, was in pregnancies. There were 28 pregnancies by 6 months. And the pregnancy risk for the bridge group was 4 times that it was for the Depo Now group. And that is some clinical evidence that shows that really a clinical outcome that really made a significant difference. So this is, again, kind of going back to the selective practice recommendations, pregnancy checklist, to think, like, what happens in real practice when we apply this broadly? And these are data from the CHOICE study in St. Louis, where almost 10,000 people had access to start any contraceptive method that they want. It was quite focused on increasing access to LARC, so 3/4 of people got an IUD or an implant. And they went back and looked at all of the people who enrolled and whether or not they met the pregnancy checklist criteria. And then they had great follow-up data on pregnancies for people. So, and this isn't the entire cohort. And there were also over 500 people, that's 6% of all the people who presented for care initially who were pregnant at the time. So they were excluded. You don't get the pregnancy checklist if you've got a pregnancy. And then what they did is they looked at the exclusion of pregnancy, basically, the negative checklist versus pregnancy not excluded. And it turns out that the majority of the pregnancies that they identified in this entire group were in the group that had the pregnancies were not excluded. But it was only 28 out of 2,100 people. And essentially, that means that's a 1.3% chance that essentially, if you were in that pregnancy not excluded group, that you were actually pregnant, which means that 99 out of 100 people would be, if you followed the pregnancy checklist, would be turned away or told to wait to start their method to prevent a single pregnancy. that doesn't seem like a really fair balance to me. And that's what the positive predictive value of essentially 1.3% is, that for those people who screened positive, their risk of actually having the condition that you're concerned about, pregnancy, was very, very low. Now, it has decent but not exceptional sensitivity, in that, so sensitivity is essentially the ability to sense, to detect that thing that you want to find out, and that's pregnancy. And the sensitivity is 78%. So of all of the pregnancies, 36, 28 were identified. And the specificity, the ability of a negative test to predict the true, to truly identify that condition, was 69%. And then the negative predictive value was, for all comers, if your test, if you were not pregnant, what was the true risk? It was very good if the test is negative in identifying, if the test is negative in identifying that you're not pregnant, was very good. So in the end, I think this is supportive of the fact that we're really overdoing it in the modern era by following the pregnancy checklist. Okay, so let's talk about some specific issues and specific methods now. These are data about the implant from our colleagues in Denver, who looked at 3,100 implant users and identified 59% of them were outside the pregnancy checklist criteria. So similar to that other group. And there was one issue with what I just presented on that last slide with the choice study. They didn't specifically look at the differences by contraceptive method choice. So that was kind of an all-comers look, but this is specific just for the implant. And they had 1,700 people, 1,726 with documented pregnancy outcomes. And they identified 10 pregnancies. So we set up this essentially same table here for the pregnancy not excluded group, 10 pregnancies out of 1,000 users. It's a 0.9%. So essentially same deal. You would have to turn away 99 people to prevent one pregnancy. And I think if you presented that to most people who were coming in, and we should be doing that to let them know, like, this is the risk if you don't wait. So we also have been looking at a bunch of different groups that have had exposure to unprotected intercourse between out to 14 days prior to having their device placed, so implants and IUD users. And specifically, if you're going to go like hunting around for looking specifically for the group of people who is at the highest risk of luteal phase pregnancy, it's not just anyone who walks in, it's the people who say, oh yeah, I had sex 6 to 14 days ago, so I may have had fertilization of an egg, but I probably haven't yet had implantation. So my pregnancy test is going to be negative. And they may have a pregnancy down the road. So we looked at this group for 83 implant users. 30 of them, 33%, had also been provided oral emergency contraception. And the data that we obtained on unprotected intercourse was part of it. All of this was part of a study, and it was distinct from what people, what was used for them to as their clinical care was provided. So if you're thinking like, wait a second, if 40 people had sex in the last 5 days, why didn't all 40 of them get emergency contraception? And it's just two different data sources for this. And then so the group of people who had unprotected intercourse in 6 to 14 days was just 43. So a small group. And there was essentially one pregnancy in this, and the risk was 1.6%. Top end of the 95% confidence interval, because it's relatively small group, is high as 8.5%. So it just, again, kind of suggests that this is a good and reasonable practice, but more data needed for the implant. And we'll talk about the copper and LNG IUD. And then now I think we can do some thinking about IUDs. So when we think about IUDs for emergency contraception, specifically the copper IUD, the pregnancy checklist looks just too restrictive. Like, we know there's this systematic review with tons of people, 7,000, who got copper, mostly copper IUDs, and their risk of pregnancy was super low, 0.1%, less than 1 in 1,000. And then I'm going to share with you some new data from a study that we've done that is hopefully going to be published very soon about using the levonorgestrel IUD for EC. So special for dialing into the webinar today, access to new information. So this is just a slide summarizing that copper IUD systematic review by Kelly Cleland and her collaborators. And tons of studies. They looked at 8 different kinds of IUDs, over 7,000 women, and again, pregnancy rate less than 1 in 1,000. And if we flip back to the selective practice recommendations for the copper IUD, it says it can be placed for emergency contraception with these specific criteria. If it's within 5 days of unprotected intercourse, but you can go further. If the day of ovulation can be estimated, then it could be inserted after 5 days after unprotected intercourse, if it's not more than 5 days after ovulation. This seems a little cumbersome for people to work through in a routine clinical day. And a reasonable person might say, could this be simpler? And I'm pretty sure it can. So one of the studies included in that systematic review was this study done from China that used copper T380 IUDs, essentially nearly the same thing as Paragard. And there were no pregnancies, zip, zero, nada. Kind of amazing. And we did a secondary analysis where we kind of cut it down to just the people who had known menstrual cycle length, so 25 to 35 days. And then we further divided this group. So we looked at the people who had unprotected intercourse in the fertile window, so the people who were at greatest risk, obviously no pregnancies there. And then there's no pregnancies in any of these groups because nobody got pregnant in the whole study. So then we looked at the 84 people who had IUD insertions greater than 5 days after ovulation, where they, again, this wouldn't meet the current CDC and WHO recommendations. No pregnancies there either. And then we also looked at the people who had, they weren't supposed to be included, but it turns out that, the world's an imperfect place. So they were supposed to limit insertions up to 5 days, and 52 people had actually reported intercourse more than 5 days before the IUD was inserted. So in none of these groups, people had a pregnancy. So it just prompted, like, we gotta look more closely at this. And all of them had a negative pregnancy test, excuse me, at the time the IUD was placed. And I think that's important and worthwhile to note. And this is just looking at the graph at the time from the onset of menses on the day that people reported their unprotected intercourse for needing to come in for the copper IUD. And this orangish arrow, excuse me, on the left is about essentially those people are at low or no risk because you're not even near ovulation. And then the orange arrow is the people who are out past ovulation. And those people past that arrow are also at very, very little risk, and it's the people in the middle. And then this is just essentially going back and looking at identifying that fertile window and no pregnancies in here. So we know the copper IUD works really, really well. So we suspected that not everybody who gets a copper IUD for EC has just had one episode of unprotected intercourse. And we figured that probably a bunch of people also had some unprotected intercourse 6 to 14 days. So we kind of dug through a bunch of different studies that we had done about the copper IUD for emergency contraception, and who were also part of this Her Salt Lake project, where we provided a bunch of people no cost contraception on the day that they presented, and we collected data on when they'd had intercourse in the lab without a method of contraception in the last 14 days. From all of these different sources, we pulled together data on 134 people. And this is a paper by Ivana Thompson that was published in Contraception in the last year. And of those 134 people, 0 pregnancies in people who got a copper IUD and reported unprotected intercourse 6 to 14 days before getting it. So again, like, this is the group, they're at the highest risk of unprotected, of luteal phase pregnancies. And essentially, with 0 pregnancies, the top end of the confidence interval becomes 2.7%. That gets you, to within the range of oral Plan B, oral levonorgestrel. Essentially, if you look at kind of all comers, and because it's less effective as BMI increases. And then we also, in the discussion of the paper, Ivana noted that there's 2 other studies, that original WU study that I had mentioned, where people had intercourse more than 5 days out, and this other paper by Norman Goldstuck. And if you combine the data from these 3 groups, no pregnancies in any of these papers, then the top end of that 95% confidence interval becomes 1.5%. So then I think at that point, we're starting to get to the place where you can have you're saying this is better than oral emergency contraception. And it seems unfair and unreasonable at that point to hold this back. And this is just a listing of the studies that were contributed data to the paper, and it's and then essentially there's a paper coming out from Christy Boras from the University of Minnesota, who worked with us and the team at Pittsburgh, and Bimla Schwartz at UC Davis. And essentially we collected a group of 187 people, 1 pregnancy, and again, the top end of the confidence interval kind of approaches 3%. So certainly, I think if you told most people who presented and wanted an IUD on whatever day of their cycle it was, and you said, well, we're not sure if this works, but we know that there's considerably, it's likely less than a 1%, or certainly less than a 3% chance of pregnancy with this, my sense is most people would wish to proceed. So there are some selective practice recommendation emergency contraception opportunities for change. And some of that is based on this study that we did that's going to be published very shortly. And it was based on the idea that we know that when people in the US are offered levonorgestrel and a copper IUD, the majority, not all, but the majority, more people will pick the LNG IUD. We know the copper IUD works great for emergency contraception, but we don't really have EC data on the levonorgestrel IUD. So we compared the pregnancy risk between these 2. And we did a participant blinded non-inferiority randomized controlled trial. We started an enrollment in August 2016. It was at 6 Planned Parenthood Association of Utah sites. All the people had at least 1 episode of unprotected intercourse within 5 days. And we did that same thing where we looked, 6 to all the way out to 14 days, and let people record that. And 40%, more than 40% of people had at least 2 or more episodes of unprotected intercourse in the last 14 days. We randomized participants, 1-to-1 to essentially Liletta or Mirena, LNG 52 milligram IUD, or the copper T 388. And these are the inclusion criteria. And basically, we didn't want to make this super restrictive. We wanted it to be like real practice. And essentially, if you walked through the door and wanted EC, you were eligible. Though we did ask that people know their menstrual cycle length and their last menstrual period within plus minus within 3 days. And then everyone got a negative urine pregnancy test. These are the exclusion criteria, which are essentially we eliminated some people who were at less risk of pregnancy. We didn't want to bias the results in that direction. So if you were using a highly effective method or breastfeeding or had used oral EC, we excluded. And then the primary outcome was a 1-month pregnancy test, urine pregnancy test, done 1 month after the IUD got placed. And we collected those data in a bunch of different ways. We sent a text message reminder and gave people, when they got their IUD, we gave them a urine pregnancy test to take home. And we told them, like, we're gonna text message you and send you a survey, and we're gonna ask you to upload a picture of the actual pregnancy test. So we're gonna ask you to come back to clinic if you're interested in a month. And we looked at all that stuff, and we got data on the urine pregnancy test result on everyone except for 48 people. And for them, we reviewed their surveys and electronic health record to identify any possible hint of a pregnancy. And essentially, the study was powered to show a 2.5% non-inferiority margin. And what that means is we wanted to show that the difference between these two things was less than 2.5%. And with that, we thought, well, that could demonstrate that, we know how well the copper works. And if this works kind of in an area that's even close to oral methods of emergency contraception, that could be enough. And we guesstimated, based on this one other study with a little bit more than 100 people who'd gotten the levonorgestrel IUD with oral Plan B, with oral levonorgestrel for emergency contraception before, with no EC failures, we thought, well, maybe the pregnancy risk for the LNG IUD is, let's say it's 1%. So it was going to be 706 people to detect that 2.5% non-inferiority margin. And I don't think we need to get into these kind of 3 different analyses, but basically we looked at the people who got an IUD and had 1-month pregnancy outcome data on by any method, that purple group. And then some standard secondary outcomes. So in the study, it was, as you can see in the top left here, it was time for EC, as the clock shows, and over 10,000 people presented to these 6 participating clinics during the study. And they all got this info sheet that essentially explained the 2 options and what we know and don't know about them. And then there was a checklist at the bottom for, are you interested? Do you want more information about the study? And then they were provided more information, or no. And the vast majority of people were not interested. Only 7% were willing to do this. And this was a blinded, randomized control trial. So you, first of all, you were going to get an IUD, but you didn't know which one. And, you were not going to know which one you got till a month later. So of the 711 people who were randomized, not all of them got an IUD. 8% of them didn't, and that was either because about half of them, the IUD was not able to be placed for a variety of reasons, or that we found out exclusion criteria existed that we didn't originally pick up prior to enrollment. But we did have data on, and so we did have insertions for 655 participants split that way. And then we had the 1-month pregnancy outcome data by urine pregnancy test and chart review for 321 copper users and 317 leave-in adjustable users. So this is the outcome by that analysis. And essentially, we had the bottom line here is we had one pregnancy in the LNG group, so 0.3% pregnancy rate, and then the copper group, 0 pregnancies, kind of as we expected. And this is the first data that I'm aware of to demonstrate that, in a prospective, in a RCT, that the LNG IUD works for EC. And then these are just these other analyses where we dropped people who didn't have IUD still at 1 month or didn't complete the urine pregnancy test. And then this is the non-inferiority analysis. And that top purple line essentially shows the risk difference. So the hexagon here shows there's a 0.3% difference between the two groups in the pregnancy risk. And then this dotted line out here shows that the 95% confidence interval doesn't approach that line. So we can say that the LNG IUD is inferior to the copper IUD for EC. And then for the secondary outcomes, this is of interest, I think, because people were randomized and blinded, and it's a very rare situation that we have these kind of data, but in a blinded fashion. So the copper users had more bleeding, had more cramping and pain, and then the LNG users had more bleeding and spotting in the first month of use, and no surprise there, right? Like that's what we expect. And the satisfaction show that the majority of people were neutral, satisfied, or very satisfied, and relatively few people were unsatisfied. And the conclusion of that, as I mentioned earlier, was the LNG IUD is not inferior. And the bottom line in collecting, I think, all of the evidence that we have at this point is people can start essentially any method that they want on the day that they present. And for people who are not meeting the checklist criteria, then conduct of a urine pregnancy test is a good and reasonable thing, especially if they're going to get an IUD. And the reason, that I think the IUD sort of had its own special category is that we know that people who have a pregnancy with an IUD in place are more likely to have a miscarriage, and they're also more likely to have choreo and an earlier delivery. But the risk that poses to the entire group of people who you're essentially turning away from getting the care that they want on the day, like turning away 99 people to essentially prevent that outcome once or less than once, in the case of the LNG IUD, does not seem reasonable. And people should have the data and be able to decide for themselves. I think that's the most important. Quick start approach for all methods in some way, shape, or form is supported by the CDC SPR. Even currently, without the data that I showed you on the LNG IUD, it says, you can place the LNG IUD and use oral EC Plan B as backup. And then menstrual cycle information helps, and a pregnancy test is only rarely needed to start today in those situations where an IUD is being placed, or you think somebody's got irregular cycles and you're just not sure and they've had recent unprotected intercourse. So I think I'm going to cut there, and happy to entertain questions if people have them, and thank you very much for your interest.
Great. Thank you, Dave. Let's see. 1 second. All right. And we did have one question come in. So people are concerned about ectopic in pregnancy with IUD in situ. And Carolyn Westhoff says this risk is very much lower in early pregnancy. Suzanne is wondering what your thoughts on this are with regards to the EC situation.
Oh, like would that change the balance of of risk for pregnancy overall and ectopic specifically? Is that, Suzanne?
Let's see if we get any further clarification from Suzanne. Yes, that's what Suzanne's referring to.
Yeah. I mean, with one pregnancy in this current study, and it was the one pregnancy we identified, which was an EC failure, it was a intrauterine pregnancy, and it was a spontaneous abortion at 10 weeks. So I don't know that we're going to come up with data on that, and the chance that we're going to properly we're going to have enough pregnancies to identify that risk would mean an awful lot of IUDs placed for emergency contraception and having pregnancy outcome data on them. So I don't have a good answer to that.
Great. Well, I'm going to follow that up with perhaps a foolhardy task of distilling all of this information into one sentence. Would it be fair to say, Dave, that for really what we're looking at is for pills, patch, ring, depot, and even implant, we can do what we can to rule out pregnancy, but really if pregnancy happens, there's no negative impact on that pregnancy, so not much cause for concern. And then for the IUD, not only can we can have an additional reassurance that the EC effect of those methods is reducing the possibility of pregnancy. Is that a fair distillation?
Yes. So sorry I didn't make it clear myself, but yes, thank you.
For the layman's ears.
No, that's right on the money.
Great.
And then there's another question about weight theoretically should make no difference on the levonorgestrel IUD efficacy. And right, like, the mode of action. So there's a lot of concern about the possible decrease in efficacy by increasing weight with especially oral levonorgestrel for emergency contraception, and somewhat with ulipristal acetate at even higher weights. And there's no reason that weight should affect this, the efficacy of IUDs for EBC. And in the data that we have, it's more than 40% of people who had a BMI over 25, and it doesn't change the risk. So certainly a good point. Thanks for bringing that up.
That's promising. We had a question about, so why do you think there is provider resistance to Quick Start? Are the barriers ideological, lack of knowledge, or is it more workflow barriers, specifically as it relates to IUDs being used as EC?
I think it's less and less over time, and the more we train people with current evidence, the less it'll be. I think it's based on the theoretical reduction in harm of preventing a luteal phase pregnancy, and now that we have enough data to show that that's not a true concern, or it's really minimal, it's incumbent upon us now to train the next generation of providers and disseminate the information to people who we can now, to show that that risk really is low, and this is a good and reasonable practice.
Yes. Any news on progress on the next version of the SPR?
That is an issue that is way beyond my control, probably beyond any individuals. But from what I understand, the next edition is they're going to start meeting within the next year, and would hope to publish the next round, I think, within probably the next two, and that's from the CDC. I'm not sure about the WHO. And I believe one of our audience members might be involved in that exercise.
Exciting. And then another question for you, Dave. So considering that gauging someone's risk of pregnancy is really dependent upon this calculation of where are they in their menstrual cycle. If you have a client who is amenorrheic, how would you, and unable to determine when the last menstrual period was or where they are in their cycle, how do you handle that?
Yeah, that's a great question. So, I think at this point, certainly for the copper IUD, we have enough data to say that if somebody is not pregnant at the time that they get it placed, collectively from all these different studies, it doesn't really matter if they have a regular or irregular cycle. Like they're almost certainly not going to have a pregnancy. The risk is very, very low. So if somebody is amenorrheic or doesn't have regular cycles, doing a urine pregnancy test and placing the copper IUD at that time is a good and reasonable thing. And then, informing people like, please check another pregnancy test, within, and it can be really anytime from 2 to 4 weeks after, and then you'll have an answer. And I think based on the data that we have now, that same approach could be used for the LNG IUD, though we don't have nearly the volume of information to share at this time. And that is one of the issues that we're going to need to figure out over time. And I think this, having sort of this first study done, it creates a more solid platform for people to look at this in different ways and gather more data in different clinical situations, and look at other outcomes of interest and concern. And it also, it's one of the, I think the next most important thing, hands down, is for us to get some information from people on how this will affect their decision making at the time of needing emergency contraception. Like, is this a real addition that will potentially change the way people think about using emergency contraception and starting the LNG IUD as a method? And how, if like when we present this information to people, how they will react and how it will help them make decisions hopefully better.
Yeah. I think that's a great point too, to consider communication to the client. And when clients are provided with this information, does that change their decision making? And I'm thinking particularly of this idea of kind of using the EC effect of a copper IUD, and given that some clients might have some discomfort with not fully knowing the mechanism of action of the copper IUD for EC, and could it potentially prevent implantation? Would that be something that you would say providers should counsel clients on if they're starting an IUD, a copper IUD, as quick start?
Yeah. So I once, I don't know how many years ago, probably 10 years ago, was called out for being a paternalistic, not nice and thoughtful person, because I didn't share that information with people who I provided care for. So for the next year, for hundreds of IUD insertions, I told every single person about the potential that the IUD could affect implantation after fertilization, and tried to explain it as succinctly as possible, and included that in my basic, counseling about the IUD for people who wanted it. And 0 people in that entire year, with a relatively large N, expressed any concern about that. And I think especially, if in the setting of emergency contraception, you have eliminated the small group of people who would be concerned. If it's certainly a good and worthwhile thing to share with people, and I think we're gonna need to figure it out. But if about what is important to people and what's essential. But I do think there is an element of this that a very small vocal group of people who have very strong feelings about this have essentially co-opted the entire process so that they've demanded that everyone think and consider this like they do. And that severely limits the availability of a whole bunch of contraceptives. And even the Supreme Court has said in the Hobby Lobby decision, even though that the group that isn't going to cover this for medical care is basing their perception of emergency contraception as an abortifacient incorrectly. Like this, the Supreme Court understood the science does not support that oral emergency contraception works as an abortifacient. It doesn't. It only works to prevent ovulation. Thus, the Supreme Court said, even though they don't get the science right, if that's their belief, then they still don't have to pay for it. And I think it's that kind of thinking that really does a disservice to the vast majority of the population who is not concerned. I think for people who are, yeah, please, inform them about it. And if you're working in a place where that's a big issue for people, or even a small issue, please, yeah, inform them about it. But that's not the rate limiting step for this as a public health and sexual and reproductive health intervention that should be offered to all people. People can decide. And I think really that's when we're doing our best care, right? It's when we present the information to people and they can decide what's right for them. It's not this way or that way all the time.
That's great, Dave. And I think also just a reassurance that understanding patient priorities and really building that rapport and relationship to find out what folks' perspectives are, that whether or not this could be problematic for them and whether it's worth bringing up. Great point. We have another question from Suzanne. I think you are all giving folks guidance now that if there's a negative pregnancy test, it's okay to place either IUD as EC with a follow-up urine pregnancy test. I think folks are still hesitant there. How are you teaching it?
Yeah, we haven't really gotten to teach it yet because, an important component of this, I think, is peer review. And I think once this current article is published and people have had time to really look over the data and think about it, and we've gotten more data from potential users on how this is going to fit into their decision making and what would be important factors around it, then we'll be in a much better position to share that information both with potential EC users and providers. But I think at this point we can say on the aggregate of the data that we have about both IUDs being used for quick start, when if you are not certain or somebody has had recent risk of pregnancy, then you should do, and you're using an IUD for EC, it's perfectly reasonable to do a urine pregnancy test in clinic and then have them repeat it in a month from that last study. I think is simple for people. If they want to do it at 2 weeks, that's certainly appropriate as well. And we hope to learn more about how to share this information with people and really welcome people's feedback on how we can best do that. But I think we're gonna do our best to disseminate the information and get feedback on it, and and implement it as widely as people are interested in doing that.
Great. Thank you so much for answering those questions, Dave. So let's talk a little bit about claiming CME credit for today's session. For those interested in claiming credit, we will email you a code and instructions once you've completed your post-webinar survey. If you've already set up a CME profile with the University of Utah before, it's very simple. Just call in to a phone number and enter the code. If you haven't done that before, you'll be asked to just complete a brief profile before claiming your credit. And one thing I would like to emphasize is that CME credit must be claimed before midnight today. At midnight, it will turn into a pumpkin. I apologize for that. And that might be perfect this month for Halloween, but probably not for your continuing education portfolio. So we'll be sending out an instruction guide, which should answer most of your questions about claiming this credit, but don't hesitate to reach out to me by email if you need any assistance. And then finally, we ask that you complete our post-webinar survey. Just like with the pre-survey, there are a few different ways to get there. You can type the URL into your browser, you can click on the link in the chat box, or you can use your smartphone to hover over the QR code. And the survey will ask if the webinar has taken place yet. Make sure to answer yes so that the appropriate questions will appear for you. It has been an absolute pleasure hosting you today, and we hope you'll join us next month for new topics in our webinar series. In November, we will welcome Dr. Catherine Fay to present on reproductive coercion. Thank you all. Take good care of yourselves. And with that, I will leave you to the survey.
Caitlin, it looks like Suzanne hopped off.
Oh, great. I'll stop the recording.